All right, we are recording. Good evening and welcome from Phoenixville Public Library. I'm Mark Pinto. Thank you for joining us tonight for this program on stroke. I'll turn things over now to our speaker, Emily. Emily, take it away. Thanks for joining us.
Thanks, Mark, and thanks everybody for joining. This is one of those nights where it's good that we're on Zoom because it's starting to get a little chilly. So I'm glad everybody can join from the comfort of their home. My name's Emily, as Mark said. I'm a speech pathologist. I practice locally, both through my private practice. So I have a private practice, the name there, Thrive Speech Pathology. And then I also have, I also work for Moss Rehab, a local rehab company that you may or may not be familiar with. And just a little bit of background in terms of experience. I've been working as a speech pathologist for about 10 years. And I've been working in all different kinds of aspects of rehab. So anywhere from hospital-based rehab, when patients initially have an illness or an injury, all the way to what I'm doing primarily now, which is outpatient. So what I like to think of as like the last car in the train, the caboose in the train, you know, once patients have done their hospital stay and maybe go to rehab or go somewhere after their hospital stay and they're back home and they're able to go to a clinic for therapy services. That's really where my work lies now. And over the past 10 years, I've worked with majority of adult patients, but some pediatric experience, but my main interest and experience lies with adults, and specifically adults with stroke, brain injuries, and with diagnosis of Parkinson's. But tonight specifically, we're going to focus on stroke education. And this may have been before some of you joined, but Mark had mentioned that you are welcome to chime in, ask questions, make comments, whatever. This is a relatively small group, so feel free to participate. And in fact, hopefully everybody's okay with this, but I may solicit a little bit of participation here in the beginning. So feel free to just unmute and chime in, okay? So myself and Uncle Sam would like to know if you know any signs, major signs of a stroke. I can't currently see my chat box, so if you want to chime in, if you could unmute anybody who wants to and just chime in with, if off the top of your head, if you know a sign or a symptom of a stroke.
Slurred speech.
Okay, yeah.
Drooping on your face on one side.
Yep. And was somebody else chiming in there?
Well, I said a similar thing, weakness on one side of the body or face.
Yeah. So the body part is an important addition. Okay. Okay, so you all did very well. That covers a lot of it. So the acronym, the most important thing that I want you to take from this discussion tonight is the acronym Be Fast. In the past it was FAST, but tonight I'd like you to remember Be Fast. And we're going to break that acronym down a little bit, but I think it's handy, especially because a stroke is an emergency situation. It's handy to have a quick acronym to keep in mind. So the B in Be Fast stands for balance. And what we can see in patients with acute stroke or a new stroke, sudden change in balance or coordination. And We can also see dizziness or just generally not steady on your feet. This balance and the next one, eyes, they weren't always included, but they are really important signs of an acute stroke. So when we talk about eyes, the E in B fast, we're looking for somebody who's, when we're noticing somebody having a sudden change in vision. So somebody might say, most commonly people will describe blurred vision, but patients also describe double vision or changes in their visual field like floaters. Any kind of new change in vision is usually something that we want to be paying attention to. And then, as you all astutely already mentioned, the F in BFAST stands for face. So someone, if you ask the person to smile, do they have a droop on one side or asymmetry? Is it even or uneven? Similarly, that can also be seen in the extremities of the body. So a quick way to judge this would be to ask someone to raise their arms in front of them. And we want to take note as to whether or not the person can raise their arms evenly. Sometimes people also complain they actually feel like their arm or hand is numb. They may have difficulty pinching or grabbing, picking things up. Or they may just feel general, what we commonly or more colloquially refer to as pins and needles sensation, or tingling, numbness, any of those unusual symptoms in the arms or legs. But again, for the purposes of brevity and the acronym, these are some really key things to look for. And then, as Mark mentioned, speech, a sudden change in speech. So slurred speech is a very common symptom that people notice. We can also see difficulty formulating language. Sometimes in certain cases, depending on where the stroke is in the brain, the patient can have difficulty even making sense. So they may be speaking fluently, but it doesn't match up with what they're trying to say or what you as the listener can understand. A quick trick can be to ask somebody to repeat a sentence that you create. Something as simple as the dog walked down the street. Ask them to repeat it back to you and see how accurate it is and how clear it is. And then the T actually doesn't stand for a symptom. As you can see there, it stands for time. So time is of the essence when you notice these symptoms for a few reasons. Number one, a stroke is an emergency situation, so it warrants immediate medical care. But number two, it warrants medical care specifically within a certain time frame. So depending on how fast someone gets to the hospital, they may have more treatment interventions available to them. In fact, there was a study that looked at long-term disability in patients with stroke, and it's actually been identified that patients who arrive to the hospital within 3 hours of their first stroke symptoms tend to have less long-term disability at about 3 months than those who didn't receive care that was as timely. Similarly, it's estimated around 30 to 40% of people only can really identify one stroke-like symptom. So something to keep in mind is that every stroke is different. So somebody may not have a symptom that you are immediately aware of. So keeping this acronym in mind, with the most important feature or the most important reminder being the aspect of time and the need to act quickly. And that will come up some more here tonight. So, oh, I apologize. My graphic there didn't translate well, but there are two major types of stroke. So the first one is an ischemic stroke, and that is the more common type of stroke. And actually, my graphic is covering my text, but you can see the ischemic stroke there visualized on the right. It's the type of stroke where a clot travels from another part of the body or elsewhere in the vascular system and blocks a major blood flow to a major part of the brain. So you can see the clot visualized there. And also patients are more at risk for this type of stroke if they have a buildup of plaque along the walls of the blood vessels and arteries. The other type of stroke that we treat, or the patients that we work with, have hemorrhagic strokes. And hemorrhagic strokes occur when there is a blood vessel burst within the brain and there's overflow of blood into areas where it doesn't belong. The brain is a very sensitive, well-oiled machine. So anything off kilter, like excess blood in an area where it shouldn't be, can really impact the functioning of that area. So these events result in loss of oxygen and nutrients to a specific area of the brain. And depending on where that is, the patient can experience a wide variety of symptoms that we'll talk about in a little bit. But notably, the majority of strokes are those that are visualized on the right, an ischemic stroke. When we talk about risk factors for stroke, there's actually some good news here. And what I mean by that is the majority of risk factors, or things that predispose you to have a stroke, can be treated or managed. Most commonly, we'll see patients with history of high blood pressure, physical inactivity, diabetes, atrial fibrillation, smoking, or excess alcohol or drug use, and as well as high cholesterol and coronary or carotid artery disease. You can see that that's a wide variety of medical, that's a wide variety of diagnoses, pre-existing conditions, but they're all manageable or treatable in some way. So if they're well controlled, it can have an impact on your likelihood of having a stroke. TIA is mentioned there, and TIA, as many may know, is the acronym for transient ischemic attack, what people commonly refer to as a, quote, mini stroke. Now, I'm not always a huge fan of that term because I think that a mini stroke to me is a stroke, and that's a separate category. The reason I think it gets the label mini stroke is because people want to signify that it's a serious event. So a TIA includes those stroke-like symptoms that we discussed in the beginning, but those symptoms resolve clinically within 24 hours. So, and they're not capturable on imaging. Now, a stroke would be capturable on some sort of imaging like an MRI or a CT. But the takeaway point is that patients that have a stroke, or excuse me, a TIA or a quote unquote mini stroke, that is a warning sign that a larger event, such as a more serious stroke or small or large, could be coming, and that the patient should get medical care regardless to address any conditions that could be treated to lessen the likelihood of a severe stroke. You'll see that down on the right, the factors that cannot be controlled are much smaller but significant. So increasing age, it's just sort of a fact of life that the older we become, the more likely we are to have a stroke, which is true of a lot of medical diagnoses and events. But it's worth mentioning. Heredity and race. Specifically, patients who are Black or Hispanic are more likely to suffer a stroke. And gender, so women are more likely to suffer a stroke than men. And of course, which may be well known to some, if you've had a stroke in the past, you are also more likely to have one in the future. I've collected some stats that I thought were just, that stood out to me. Every year we see upwards of almost 800,000 United States citizens that have a stroke, Americans that have had a stroke. Or another way of looking at it on a much smaller scale is someone in the United States has a stroke about every 40 seconds, which is pretty remarkable in my mind. What my work lies in is the long-term effects of stroke. And we know that stroke is a leading cause of long-term disability. We also know it's a leading cause of death for Americans. And a very large percentage of those strokes are ischemic strokes, those ones that result from a blockage in the blood vessels of the brain. So when we look at the impact of a stroke, either short or long term, you can break it down into these areas. And most of my patients tell me they were more aware of the physical impact, the potential physical impact of a stroke, not as much the other areas. So we'll briefly talk about the physical, sensory, and emotional potential impacts from stroke. But what my work really focuses on is the cognitive communication impacts of stroke. So just briefly, when we look at physical impact, it mirrors some of the early signs. So things like weakness on one side of the body, or both, depending on the severity and the scope of the stroke. Difficulty completing activities of daily living, such as anywhere from basic activities of daily living, like getting in and out of bed, showering, dressing, all the way to walking, running, balancing yourself in space. There's a really wide range, but just thinking strictly appearance and body function, often our patients have weakness on one or both sides of the body, usually one worse than the other, and can have related balance and walking difficulty, as well as difficulty completing daily tasks. Sensory impacts are really interesting. So patients can have sensory changes anywhere from vision changes, from not seeing one side or the other on surfaces. So several patients I'm working right now have something called left neglect, which means a part of their left visual field is not immediately visible to them. And they have to work additionally to see, to get all the information presented in their visual field. Sensory impact can look like difficulty feeling hot or cold on the side where on the side that's affected, and it can also look like difficulty getting a pain sensation. So you can imagine those things could cause a safety concern, like if you couldn't feel that a burner on the stove was hot, something like that. And then emotion and mood. Having a stroke does place you at increased risk of anxiety and depression, but it also can lead to unexpected personality changes. Patients that I've worked with range anywhere from being really prone to laughing at inappropriate times, the other end of the spectrum, uncontrollable crying and feelings of emotion, even when something they don't necessarily feel like it's something that would have made them emotional before. What I am going to get into a little more detail about is the role of the speech therapist and what cognition and communication impacts we can have. So a stroke can impact many things, but specifically the patients that we work with have difficulty potentially with speech. Another way of saying that is articulation. And of course, that's included in our name of what we, that's in my title, speech pathologist, but people are surprised to find out some of the other things that I'll talk about. So, but first and foremost, speech or articulation and oral motor function. So when I say oral motor function, what I'm referring to is the strength and range of motion of the oral structures. So we mentioned that facial drooping, facial asymmetry in the beginning, and that can linger on. For some people, that does not resolve. And so you can imagine if that doesn't resolve, you could have leaking from that side when you're drinking a fluid. You could have saliva leak from that side. It could affect the clarity of your speech. So I include those things together because they're closely related. Some of the more formal terms that we use are dysarthria and apraxia. And I won't go into great detail, but dysarthria is the term that we use when there's a speech difficulty caused by weakness in the musculature, and apraxia is difficulty planning the movements for speech. And some people, have never heard these terms before when they enter my office. So just kind of explaining to people what's going on can be some of the first steps in the first minutes spent in therapy. We differentiate speech from language. So language is really an individual's ability to express their thoughts, their ideas, their needs, what they want, or understand them coming from other people. So basically your ability to express and understand. And when somebody has a loss of either of those abilities, we use the term aphasia, and you may already be familiar with the term aphasia from just popular life. You may be familiar with somebody who has struggled with aphasia before. Oh, excuse me. Sorry, I lost my screen there for a second. Okay, there we are. So thinking skills, cognition. So this is another surprising one, not to somebody who's maybe struggled with this, but definitely to somebody who this is new to. So thinking skills, we formally refer to as cognition. So that can include anything from paying attention, remembering, problem solving, organizing, planning, all of the thinking skills that we use to get things done in the world on a daily basis. The next one I have mentioned here is swallowing. So a stroke can affect how we chew, how we move food back in our mouth, how we swallow, and it can impact whether or not our swallowing is safe, our eating and swallowing is safe. So someone who's had a stroke, depending on where their stroke is, that always goes without saying in these cases. It's not true for everybody. It depends on the site. That person could be at risk for aspirating food into their lungs or choking. And actually, many hospitals have adopted protocols where patients are at least screened for swallowing issues because of the potential that the stroke has impacted their swallowing function. And that's obviously a health and safety issue if someone's at risk of choking. So, it's important to at least screen for that. Oh, and I'm sorry, I didn't mention voice, but patients can also experience changes in regard to their voice quality, their voice loudness, and that kind of goes in line with the speech changes. One of the things that I frequently, and one of the pieces of information that I'm frequently sharing with patients and their family is that the way we communicate with individuals who've had a stroke sometimes may need to change depending on whether this impacted their communication. But the main thing that I always remind people is difficulty communicating does not equate to lack of intelligence. One of the biggest concerns and one of the biggest concerns of the community of individuals with aphasia is that they're often treated as though they are not as intelligent. And one of the things that I really try to stress to caregivers, to family, to friends, is that it's not as though the person has lost their intelligence or their knowledge. They may have lost the ability to access it or communicate it, but their intellect remains intact. So we want to remember that when we're communicating with them. Some things that can be helpful, though, however, is to keep your communication short and straightforward, but never childlike, never the way you would speak to a small child. So no change in intonation in terms of making it more high-pitched or louder. They can hear you unless they have a pre-existing hearing condition, which in that case, it's something slightly different. But the idea is that you want to be simple and succinct and straightforward in your communication, but you don't want to be condescending or talk down to them. You may also want to consider just a slightly slower rate of speech, again, keeping in mind that you're being as respectful as possible. Something that can be really helpful can also be to eliminate distractions in the room. We're often used to communicating with the television on in the background. We often have our phones nearby. And I think that something really important to keep in mind, but that may be overlooked, is that those things can detract from a conversation, particularly with someone who's already having difficulty. We always want to be sure to face the person directly. Seems like it would go without saying, but a lot of my patients tell me their husband or wife may try to talk to them from the next room. And it can be really helpful to face and sit with the person to get all of the information, including the nonverbal communication that's so important for all types of communication. And then really looking to the person to make sure that you are sure that they understood you. So usually we're pretty good at showing the other person that we didn't understand. We might have a puzzled look on our face if we didn't understand, or if we did understand, we might be nodding and agreeing or smiling along to kind of signal to the other person that we're following what they say. And so look for those signs from the person. Allowing extra time is really important for the person to process information and to respond to you. A lot of my patients tell me they would really prefer that people did not finish their sentences or finish their thoughts unless, of course, asked to. which is a different situation. And then you might want to consider finding other ways to communicate with the person. So maybe somebody isn't able to describe the word that they mean, but maybe they're able to draw it, or maybe they're able to spell it by pointing to letters in the alphabet, on an alphabet board. This is really where a skilled speech pathologist is helpful, because part of our role is to help the person trial through some of these options and decide what is the best alternate or supportive way of communicating. And that can start as early as the hospital. So speaking of, stroke care really begins with prevention. So before we even get to the hospital, addressing those risk factors that we are able to address, and keeping in mind the other ones that may place us at increased risk. The next sort of step in the chain of stroke treatment and rehabilitation is to remember that acronym from the beginning: be fast. The stroke care can begin as soon as the patient enters the hospital, and the sooner the better. There are a variety of amazing medications and procedures that can reduce long-term impact. Once a patient is hospitalized, the goal then becomes to medically manage and stabilize them, and also initiate any other support services or other medical providers that might be part of that might benefit them to be part of their team. So this is really where rehab starts. This is really where we start to introduce speech therapy, physical therapy, occupational therapy, and then the list continues from there. And I do include a list later on, but the idea is the earlier the better for all of this. Once a patient is stabilized and just ready to be discharged from the hospital, they could go to a variety of places. So some patients, typically the patients with a more mild stroke, may go home and could benefit from nursing or therapy services in the home. Some patients may go to something called inpatient rehabilitation, which is essentially a continuation of their hospital stay, but with an increased focus on therapy. So patients in inpatient rehabilitation are required to have 3 hours of therapy a day. That typically includes physical therapy, occupational therapy, and speech therapy. It can be broken down in various ways, but the idea is the patient may not be medically ready to go home, but they do need to start really kicking in their therapy care. So that's where patients may qualify for inpatient rehabilitation. We also see patients go to skilled nursing, which is a more long-term rehab setting. And these patients may not be able to tolerate or may not be appropriate for 3 hours of therapy today. 3 hours of therapy a day. And then lastly, patients could come to see us. They may go home, but be well enough to go out into the community or be prepared to go out in the community on an outpatient basis, which is where I see patients currently. And we typically see patients anywhere from 1 to 3 times a week. So as I mentioned, there is a wide variety of practitioners involved in stroke recovery. Anyone from neurologists and ophthalmologists, cardiologists on the physician side, but then we bring in all of the therapists, speech, occupational, physical, something called recreational therapists. Patients may benefit from nutritionists, social workers, and for those emotional mood changes that I described earlier, patients may also benefit from mental health care. And honestly, again, many would continue to benefit from being screened for any mental health impact or changes, particularly because a stroke is a traumatic medical event. And some people describe the experience of seemingly their life changing in quite literally in an instant. So, as someone who works one-to-one with patients, I'm often really pushing and encouraging their participation in mental health care as they see fit and as their family sees fit. Just as a related note to rehab, one of the really fascinating things that we study and that we use to guide our practice in rehab are the principles of neuroplasticity. Neuroplasticity is the term that we use to describe the ability of the brain to learn and change, particularly after an event such as a stroke or a brain injury. And these are the things that we keep in mind as practitioners that would be beneficial or that could drive good brain change when somebody comes into our office. So the old adage, if you don't use it, you lose it, remains true and is actually scientifically proven. So failure to use a certain area of the brain can result in that skill or that ability degrading over time. On the opposite end of that spectrum, we use a skill and specifically target that skill, well, we can improve it. Salience matters. So we need to be working on with our patients what actually is salient and important to them. What skills did they want to improve and what do they want to get back to? A couple others that I'll mention. Repetition matters. So it matters whether or not we do something repeatedly and at a high frequency. Not only does it matter if we do something at a high frequency, it also matters if we do something in an intense fashion. If we are really sort of relentless with our patients at having them go full out doing the task that we want them to do and repeating it many times. We use this to encourage our patients to take what they learn in therapy and continue it in the home environment, do their homework, so to speak. And that really gets the idea of the patients drive their therapy and they're the ones that really, it's up to them to take what they learn in therapy and continue their practice at home. So I think that it's nice to have there's actual research that supports the idea that keeping these principles in mind when you are working with a patient after a stroke or a brain injury can support their overall learning and recovery. And in fact, it has applications to our own learning for those of us who aren't recovering from a stroke. The more we do something, the more likely our brain is to learn it. And that seems like it's common sense, but in fact, it's things to keep in mind when we're trying to learn a new skill. Or like, for instance, many adults like to try to learn a new language. Well, if you don't do that at a high intensity, very specifically, very frequently, and if it's not truly important and self-motivating to you, your likelihood of really truly learning can be diminished. Some important milestones to keep in mind. There's a lot of mixed information about so-called recovery milestones, or when will I be back to 100%? A lot of people ask me, when will I feel like I'm normal again? And what we really shift the focus to is general timeframes for recovery. So we know that the first 1 to 3 months are the most important and when patients will see the most improvement. So it's really important that they get good, high quality rehab care right away. And this is also the time where patients will also see some, what we call the phenomenon spontaneous recovery. The brain naturally heals itself and starts to improve just on its own without rehab. But rehab really is the factor that pushes it forward even more. And then beyond 6 months, recovery is slow, but still possible well beyond the 6-month mark. Everybody has the potential to benefit from those principles that we just reviewed. But certainly the earlier months, there may be a quicker, more intense period of recovery. And then around the 6-month to a year mark is when we tend to see a more slowed recovery, but that doesn't mean it's not possible. So that's always what I'm trying to communicate with my patients. And so related to that, there's a number of factors that can impact somebody's recovery from a stroke. So first of all, no two patients are the same. So all of these factors and beyond can impact how quickly and how markedly they recover. So age at the time of stroke, how severe the stroke was, where the stroke was in their brain, how motivated they are, and family support. So I really, really see this one play out in my setting as an outpatient. My patients with a lot of family support and in addition to their own motivation for recovery, tend to have sort of an advantage over those who don't have those things. And it's really just about encouraging that follow through. They have their own sort of built-in coaches pushing them when I'm not there. And as we talked about, that repetition and intensity really matters. So those patients really benefit from having support. How your physical and cognitive abilities before a stroke can impact your recovery, and the quality, frequency, intensity of your rehab services. So if you have high quality early rehab care, that can make a difference. I wanted to include some really great resources. The American Stroke Association, I won't read through all of these, but they're all great places where you can learn more. I also included the American Speech, Language, and Hearing Association's website. And I just wanted to mention that because it's not only beneficial for learning more about some of the topics that we talked about tonight, it's also a great place to find a speech pathologist, not only for somebody who's had a stroke, but for a child, if somebody has concerns about their child's language development, all the way through the elderly population. On the American Speech, Language, and Hearing Association website, you can type in your zip code and you can identify speech pathologists in your area as well as their areas of specialty. So it's a very, very useful tool to kind of narrow your search. A lot of patients tell me it's difficult to find speech pathologists. So this is a really great tool to use. You can also search through your insurance company where you would normally type in or ask about a provider, a physician. You can also type in speech therapy or speech pathology. And remember, you can make a difference in someone's stroke recovery. So I bring Uncle Sam back to remind you that it's so important that you look for those early signs of stroke and either get yourself or get your loved one medical attention. I'm going to leave any time for questions, and I just wanted to also put my information up there. As I mentioned, I have a private practice, mainly working on home visits and working with patients via home visits and teletherapy visits. And I also work for a rehab facility. So I just wanted to put my information there in case anybody had follow-up questions that they didn't want to ask tonight, or in the future had a loved one or they themselves needed speech pathology services. They are readily available in Montgomery County. So if these settings are not appropriate or not something that you're looking for, I can help connect you with someone who does match your needs, whatever they may be. All right, that's it for me, Mark. And of course, if anybody has any questions.
Yeah, any questions, feel free to unmute yourselves, folks.
And if not, like I said, the contact information's there, so anybody can feel free to reach out after.
Not a question, but great job. And be fast.
Thank you.
Yes. Okay.
Just
Well, great.
wanted to know.
Is there someone there with a question?
Doesn't look like
Okay,
it.
great. Emily, thanks so much.
Yeah.
And
Thanks
thank
for-
you everyone for logging in tonight.
Yeah, thanks so much for having me, and thanks everybody for your attention and participation. I appreciate it.
Great. Thanks, everybody. Have a great night. Take
Thank
care.
Have a great night. Thank you. Bye.